What's going on, guys? All right, we are gonna pick up where we left off yesterday. It kind of sucked. The live post didn't load properly afterwards. The audio was all messed up. Some of you guys may have seen that. I didn't realize that until like a couple hours later. But that's good. Blessing in disguise. I guess it got me to open up a YouTube channel. For anyone who looked at it, it's literally nothing right now. But hey, that's the start, and it's gonna go places, I guarantee you. Thanks to you guys. So we're gonna pick up from yesterday. We were talking about that CT scan where all this last couple of days, the talk has been stemmed from was that one CT head. And I asked you, was this a normal head? Was this not a normal head? How old was the patient? That kind of thing. So let's start from there. Just to reiterate and just to remind anybody who didn't get a chance to look back at the head CT from yesterday, this is what we were dealing with. This is what I posted yesterday. And I asked, is this a normal head? And then I asked, or I think it was something along the lines of surgical consultation or send the patient home. Then I said, how old is this patient? So let's talk about, and again, hey, thanks for anybody who listened yesterday and is back on today. I appreciate it, but this is going to really kind of solidify things for you if you're hearing it for the second time over. So this is let's start off with what a normal head CT should look like. So this is what a normal head CT should look like. We talked about the gyri, which are up here, and we talked about the sulci, which are the kind of like the valleys going down, and they're dark because it's basically filled with CSF. It's a young patient. We don't really see any prominence of the sulci, and we don't see any thinning really of the gyri. As opposed to here, we see really prominent sulci. Basically, the sylvian fissures are wide open. That's a dead giveaway that there's some cerebral atrophy. If you can see this right here, this is what we call the ribbon, the cortical ribbon right here. This is the sylvian fissure, which is just wide open. There's a lot of CSF that you can see right here. So this is a lot of brain atrophy. Again, comparing to here, I can point out areas where there are thinned gyri, and then there's a lot of CSF or sulci that are really prominent. So is this actual hydrocephalus is the question. And what we were talking about yesterday is there's brain volume loss. It's so atrophied. There's so less brain than when it started, so much less brain, that the CSF spaces or the ventricles, they just kind of passively got bigger. They didn't actually get bigger because there's increased pressure, there's an obstruction, nothing like that. Let's just imagine that this is the brain parenchyma is the letter A. The CSF spaces are the letter B. If B shrinks, A is going to be like, hey, I got more room to occupy the same amount of area. All that the brain wants to do is just occupy the intracranial space. So if there's less brain parenchyma, well, there's going to be more CSF spaces. So this is prominence of the CSF spaces or ex-vacuo dilatation of the CSF spaces. And I mentioned yesterday that I try to refrain from using the words hydrocephalus, obstructive, anything like that in this type of situation. And the reason I refrain from using it here is because somebody may read the word hydrocephalus in the report and say, oh my God, there's an acute etiology. We need to get a neurosurgical consultation. We need to get them on board. Does this patient need a shunt? Something like that. So I kind of bypass all that. And I say there is ex-vacuo dilatation of the CSF spaces. Imagine with the brain parenchyma so atrophied, I don't know, this is a weird way, however you want to remember it, but this is just off the top of my head right now, is a vacuum cleaner, ex-vacuo, so the vacuum cleaner is kind of just sucking open the CSF spaces and it's dilating out. So once again, ex-vacuo dilatation of the CSF spaces, old brain, this guy's probably 80 something years old, he's partied a little too hard in his life, or he has dementia. He's run, I don't know, maybe drugs. He's had a lot of diabetes complications, hypertension complications. And this other thing that I want to talk about on this scan specifically, how can I say that he's had some chronic long-term issues? Because if you look, so again, CSF, dark. Look at the density right here. It's dark, 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 dark. Quick side note, because you love when I go on side notes, and I do it all the time. When I'm talking about CT, The correct terminology to use for CT is density and attenuation, those two things. So you need to remember, when I'm talking about CT, I'm gonna say the words density and attenuation. Either it has decreased or increased attenuation or decrease and increased density. Those are the two words for CT. Remember, echogenicity is talking about ultrasound, and MRI is talking about signal characteristics for MRI, okay? So once again, we have CSF spaces right here. They're dilated up. Then we have the gray matter, which is right here, okay? We talked about the atrophy. This is the white matter. This area between the CSF and between these bright areas that are on the periphery of the brain, these areas are all white matter, okay? Why does this area look darker? This looks darker. Some areas are not as dark. It's kind of patchy. And then when you look at the normal brain parenchyma, which is over here, okay, this is not really dark. This is all just kind of uniform. Everything looks the exact same. There's no areas of patching. This is like, why is this darker than here, then like down here, then like over here? So this is what we call chronic microvascular ischemic changes. That means either this patient has complications with diabetes, hypertension. Those are the two main things. Yes, there are other things that can cause it, drugs, illegal or not illegal, just, prescription drugs. But this is chronic microvascular ischemic changes. These are basically the little tiny blood vessels at the ends of the arterioles, let's talk about. And they can either infarct or pop open and bleed just a little bit. They're not infarcts. Like, I'm not talking about like an MCA infarct. I'm not talking about a huge stroke. I'm talking about just little tiny things that nobody's gonna notice. But when we read these brain CTs, we notice them all the time. Just to reiterate for anybody who's joining, ex-vacuo dilatation of the CSF spaces, not actually hydrocephalus. I have prominence of the sulci, which are these little valleys right here full of CSF. Those are prominent. Why are they prominent? Because the brain parenchyma or the gyri have atrophied. This is an atrophied brain, and the CSF spaces are now occupying that area that it's allowed to now because the brain parenchyma has shrunk. This is right here, chronic microvascular ischemic changes. This is a normal brain. I talked about this yesterday too. You will see this calcification, and this calcification on 90% of your brain CTs. Do not worry about that when you open up a CT. Choroid plexus, and this is the pineal gland that's lit up right here. I shouldn't say lit up, that's calcification. When I say lit up, that sounds like I'm talking about contrast. So any questions so far? Because I'm gonna move on to the next head CT while I get a quick drink of water. The next head CT, so we got two kind of spectrum. We have one side, we have that normal brain CT. Then in the middle, we have that atrophied brain. Now check this out. Look at this brain. You can see the difference now that I've pointed other secondary findings to you. Look at these ventricles. These ventricles are massive. There is ventriculomegaly, right? These are huge, okay? Look over here. Yes, they're big. Some people may say, oh, these two exams are the exact same. Do you see prominent sulci and atrophied gyri over here? Like this? No, you don't. Can you tell me where the Sylvian fissure is? This guy that's wide open now? You can't tell me that where it is over here. So this is a young brain that does have hydrocephalus, and it's not because of an atrophied brain. This is because there is some underlying cause for it, okay? Now, talking about the causes, somebody asked yesterday, what is the difference between obstructive versus non-obstructive, okay? And I really want to tell you guys to be careful with the terminology when you use it and really think about the terminology before you use it. It was used correctly yesterday, don't get me wrong, but there's obstructive hydrocephalus, which is non-communicating, okay? So if you think about it, there's an obstruction somewhere, so there's no communication between here and here. So obstructive hydrocephalus, non-communicating. Then you have non-obstructive, so this flows to this meaning maybe it's a lateral ventricles and this may be a fourth ventricle. So it's non-obstructive and it's communicating. So you kind of see how there can be kind of confused. One has non, one doesn't, and they go kind of opposites with each other. But if you really break down the terminology, you'll understand what they mean. Let's talk about obstructive hydrocephalus right now, okay? Obstructive hydrocephalus is basically a connection between, let's use, for example, you know what, actually, let's even back it up. We're gonna talk about the correct CSF flow starting from the ventricles, starting from these lateral ventricles. Where should they go from here? They should go from the lateral ventricles to the third ventricle, which is right in the middle, and then it's gonna go down through an aqueduct, and it's gonna go to the fourth ventricle, and then from there, it's gonna go through the foramen magnum, which is the hole basically in the bottom of the skull base, and then it's gonna go down into the spinal canal. That's the normal flow that this all should be happening, okay? So if you have an obstructive hydrocephalus somewhere, okay, that means there is an obstruction in that process of flow, that normal flow. So let's use, for example, there is an obstruction at the fourth ventricle. Between the aqueduct, between the third ventricle and the fourth ventricle, there's something that's blocking that. I don't know what it is. Could be a malignancy, could be infection, could be something, and I'll get to other reasons why. So you have an obstructive hydrocephalus that's stopping the third from going to the fourth. That means everything upstream is gonna be ballooned up. Everything upstream is gonna look like this, okay? The aqueduct that's going from the third to the fourth will be kind of snipped off or obstructed. Everything upstream is ballooned up, and the fourth ventricle you're gonna look at is basically completely collapsed. So that's obstructive hydrocephalus. Non-obstructive hydrocephalus, AKA communicating hydrocephalus, is there's no external obstruction, there's no internal obstruction. What is happening is what the CSF is supposed to do. It's supposed to flow around, and then it's supposed to get into arachnoid granulations. These arachnoid granulations, don't worry about where they are, okay? They're all throughout the brain in specific parts exactly. They are gonna reabsorb the CSF, and your CSF is constantly being made. So they're gonna, sorry, I'll answer, I'll get to this later. It's kind of distracting if you don't mind, thanks. So the communicating hydrocephalus, or the non-obstructing hydrocephalus, is basically those arachnoid granulations are not allowed to correctly reabsorb that CSF and get back into the body and then make more CSF. One of the main causes, we'll talk about two of the main causes about please, this is, okay. Hold on one second here. One of the main causes about non-obstructing hydrocephalus is if somebody has a subarachnoid hemorrhage. There's different types of hemorrhage that can happen, and I can get to them actually in a later post, but the different types of hemorrhage, the main one being subarachnoid hemorrhage, it's gonna bleed into the subarachnoid spaces, which are basically these spaces right here, and it'll bleed into there, and it'll eventually leak into the ventricles. And then it'll gum up those arachnoid granulations, okay? So when those arachnoid granulations are really gummed up, that means they can't absorb that CSF. Those ventricles will dilate up. It will cause pressure, it'll cause headaches, it'll cause other secondary symptoms. You can have a lot of neurologic effects. This happens a lot in trauma patients. These patients will have subarachnoid bleeds, other bleeds too, subdural, epidural, whatever it is, but they'll have these subarachnoid bleeds. They'll leak into the ventricular system, cause these arachnoid granulations to gum up. CSF can't be reabsorbed. They're gonna get hydrocephalus, and the neurosurgeon puts in a drain, extraventricular drain, to drain that CSF. That's what non-obstructive communicating hydrocephalus is. You can see how kind of annoying the terminology is and how confusing it can get. The other thing that I wanted to talk about that we touched upon yesterday was Chiari malformations, because I used that as an example as to why obstructive hydrocephalus can happen. If you guys remember what Chiari malformation is, there's multiple types. There's actually, I think, 4 or 5 different types. The ones you need to remember for med school, for the boards, for other residencies, medicine, EM, there's 2 main types of Chiari malformation. Let's talk about number 1. Chiari I malformation is basically the cerebellar tonsils are just a little bit lower than they should be. They're just a little bit low into the magnum foramen, and they're not really causing too many problems. They can be completely asymptomatic as well. So these patients can lead a normal life, no issues at all, but they will have the cerebellar tonsils that are just a little too low. If they do start complaining of symptoms, they're having headaches, they're having neurological issues because there is actual obstruction of the flow. Because remember I was telling you, Ventricular system goes to the third ventricle, down the cerebral aqueduct to the fourth ventricle, out the magnum foramen, and then down into the spinal column. So if you have an issue right at that magnum foramen where those cerebellar tonsils are pinching off the cord or pinching off the flow of CSF, you're gonna have obstructive hydrocephalus. So the way that a neurosurgeon can resolve that is do a suboccipital craniotomy. Basically the occipital bone, which is back here, they can drill out a little piece of bone about that big, and it'll give that area a little bit more room to breathe. It won't be as constricted, those cerebellar tonsils, and the CSF can flow through there. That's Chiari I. This is the one that's commonly seen with a syrinx, okay? So that's a little tiny dilated area of fluid in the canal, the spinal cord itself, I should say. So remember that, buzzwords for USMLE step 1, for boards, Chiari I, syrinx, remember that, okay? Chiari II is a completely different beast. Chiari II has a lot of issues with it. These are not normal patients walking around with no neurologic issues at all. Chiari II can be very detrimental. I have cases that I pulled up here for you guys, and one of the main theories behind Chiari II is and this was one of the cases that I posted, the last MRI. If anybody was wondering if that was an MRI CT, the very last one of the spine, it was an MRI of the lumbar spine. So the very last case showed the lumbar spine, and it showed the CSF kind of coming down, and then there's a huge defect in the epidural space in the back of the column. Let me just pull it up here. We can show, let's go here. Okay, this is the last thing that I posted up, okay? So this is an MRI of the spine. Remember, if it's a CT, there is no way I'm gonna see CSF like this on a CT. You just don't have the contrast resolution. There's no way that I'm gonna see the cord this nicely on a CT. So if you can see the cord, if you can see little fibers like this, if you can see the disc and actual disc space, this is an MRI, so remember that. So this is a lumbar spine MRI. Look at this defect right here. There's a huge defect. There absolutely should not have the CSF that's coming out, spilling out like this. And look at this cord. This cord is actually pulled down. Okay, so and even maybe tethered down here. So this thing is pulled all the way down. Real quick, step 1, USMLE boards, everything again. The cord, the conus medullaris, the end of the actual cord itself should be around up here, L1, L2-ish. Okay, some can be lower, some can be higher. That's ish around the normal area of the cord itself. Then you have little fibers that kind of come down, cauda equina, the horse's tail, however you want to remember it. That's what goes below L1, L2. So why do I not see these fibers coming down here? Why do I continuously see that cord actually going all the way down here? So this is the theory behind a Chiari II malformation, is that in utero, this defect posteriorly right here caused all this CSF and all the fibers, the nerve fibers, the cord, to everything to be yanked down. Imagine this as a negative suction. If anybody's placed a line or anything, you know what I'm talking about when you go in with a syringe and you pull back on the syringe, you have negative aspiration. So you have this back pressure built up. So imagine this back pressure that's spilling out the bottom of the cord. It's spilling out the sacral area. What is going to happen up here? Because this is all connected. Remember, CSF, ventricles, third ventricle, fourth ventricle, foramen magnum, down into the cord. That's all connected. So if there's a leak down below in the sacral area and you have a myelomeningocele, if there's a leak and everything's being yanked down, the whole brain is going to get yanked down because it's all just a negative now kind of environment, a negative pressure environment is what I'm trying to say. So everything's just going to sag down. So if it sags down so much, the cerebellar tonsils, they're not going to just be low-lying. They're going to get just wedged down into that spinal canal, and it's going to cause just bad hydrocephalus. Everything's going to be dilated up. There's so many additional findings that can be seen with Chiari II, like corpus dysgenesis, the corpus callosum's not made. A lot of stuff can happen. That's the main theory behind Chiari II. Again, these are sick patients. They will forever have neurological defects and effects, causes of this. Chiari I, remember, can be completely normal. If they become symptomatic, they can do a suboccipital craniotomy, take out that little piece of bone in the back, and decompress that posterior fossa. Here's a MRI of the brain of this same patient. These are the cerebellar tonsils that I keep talking about.
Look at how tight everything is back here. Where is the spinal fluid back here? You don't really see it. So there's a lot of issues going on back here. Everything's sagged down. So this is what the secondary findings up top of Chiari II can look like. Just to reiterate, for Chiari, number 1, can be fine, can be symptomatic, suboccipital craniotomy. Remember the syrinx. Syrinx is going to be that little fluid-filled dilated space in the cord itself. Remember, Chiari II can be bad. It is bad. No, it not can be. It is bad. Myelomeningocele, everything's yanked down. It causes this, the cerebellar tonsils, to herniate down into the canal. That's Chiari II. There's other types of Chiari. I think it goes up again to like 5. There's like type 3 where you get an encephalocele. So instead of something like, Instead of something like this, you actually get CSF to herniate out the area in the brain. So that's like Chiari 3. There's like a 2.5. Don't worry about any of that. All you guys got to worry about 1 and 2. Those are the board's test-worthy questions. Syrinx number 1, 2, myelomeningocele. Don't forget that. That's a lot of information. What can I answer for you while I drink some water? T2 image, yes. I'm glad you mentioned that. This is a T2 image. I don't think, other than radiology residents, will need to know if this is T1 or T2. I don't find it fair if if a medicine attending or a family medicine or EM, if they asked you about that, I don't think they would, but it's a T2. Anytime, what I can tell you is, I was actually talking to a med student today. We pulled up an MRI, and it was an abdominal MRI, and we were looking for the appendix. And there's one sequence. So when I look at an MRI, I'm looking at 30 different sequences. I'm piecing everything together from 30 different sequences, and I'm making a final diagnosis. When somebody who's a non-radiology resident, and I love tailoring to that person, a non-radiology resident, when you pull up a body MRI and you're looking for inflammation anywhere, all you have to go to is one sequence. It will look very dark. It's a T2 fat saturated sequence. Real quick, T2 means fluid will be bright. Look at how bright this fluid is. Look at how bright these disc spaces are. By the way, fun little fact, going off on a tangent again, I love doing this. Why are the disc spaces bright? Because they're filled with fluid. It is hydrated. It is a hydrated disc. Why do old patients have low signal in their disc spaces? Because their discs are dehydrated over age. So if you have a nice hydrated patient, these discs are nice and hydrated. Not like hydrated, he's drinking water and his disc became hydrated. No. These are basically no trauma, and when I'm saying like micro trauma over the years, nothing has happened. These are pristine. But again, he's obviously got that. So T2, which is bright fluid, if you want to know if the fluid is bright or not, these are your go-to spots. Look at the CSF, look at the gallbladder, and look at the actual bladder itself. If you can find any one of those 3 and it is bright, it is a T2 sequence. Then go to the one that just looks dark. So if the whole sequence is all the way dark, like the pancreas is dark, the liver is dark, everything's dark, but the only things that are bright are the gallbladder, the CSF, and the bladder. That's your go-to sequence, and find anything there that looks inflamed or there's extra T2 signal. How can you tell if an old patient actually... Oh, by the way, I need to be reading these out loud because I tried uploading to YouTube and none of these comments come in. So I'm gonna read these questions out loud so later for whoever's watching this will know what I am talking about. So here we go. How can we tell if an old patient actually has hydrocephalus on CT? Awesome question. That's a tough question. That is a good question. So 1, a radiologist's best friend. What is that? No, it's not headphones because I listen to music all the time when I'm reading. Number 2 is not coffee, and that is true too. It is a prior study. Look for a prior study. If you have a prior study, you can compare the two. It will make the world of a difference for you. If you don't have that, that sucks. But there are secondary findings that you can look for. 1, when I'm looking at white matter disease that we went over before, the white matter disease, and it's kind of a characteristic-ish look to it, there will be something called transependymal flow. Oh, we actually touched upon that yesterday too. Transependymal flow is basically CSF is built up and it's pressurized. There's way too much of it, whether it's obstructive or non-obstructive, and that flow will leak out of the ventricular system and then kind of leak into the white matter. So if you have symmetric, I do work, man. I do work. I actually work a lot, and I'm working right now. If you have obstructive or non-obstructive hydrocephalus, that flow is going to flow out of the ventricles and it's going to go into the white matter. It's going to be kind of symmetric. So you will get this very symmetric, homogeneous hypoattenuation. Remember, CT buzzwords, hypoattenuation or attenuation in density, that's CT. When I was talking about MRI earlier, remember that's signal and intensity. Those are the two words. Just to clear things up and just to finish everything. Ultrasound, echogenicity. So those are all the words used to describe this. So now you guys don't need to be interchanging stuff back and forth. Now you guys know. You look good. What else? Any other questions? Difference between T2 flare and T1. Good question. T2, okay, so T1, for anybody who's not in radiology, doesn't really need to know about this. Anybody who's interested in radiology, here we go. I'm about to go a little radiology 201 right now. So T1, a T1 sequence, and we're talking about brain right now because flare is not really used other than in the brain. So T1 sequence, the white matter will be white. The dark matter or the gray matter will be dark. T2, it's flipped. So the white matter will be brighter, gray matter will be, no, I said that wrong. Now I've flipped myself. White matter's white, dark matter's dark on T1, and then flare is the opposite. So that's the way to remember it. I don't know how you want to try to remember it. T1, maybe, I don't know how I do it. I think I do like, I don't remember what my mnemonic used to be. But T1, that's your normal, white is white. How early can Chiari II? I didn't save it here. Chiari II can be diagnosed in utero. As far as weeks, I couldn't tell you exactly how many weeks, but we do intrauterine MRI, fetal MRI. Every once in a while, I have a really good case of it. I saved it. I'm going to post that as a real legit post soon. It was Chiari II in utero. So basically, the mother went into the MRI scanner. Her fetus was, 28 weeks. I don't remember exactly how old. About 28 weeks gestation, maybe 30 weeks gestation. And you can see the cerebellar herniation into the canal. You can see the myelomeningocele. You can see the defect. And you can see the obstructive hydrocephalus. The hydrocephalus that is obstructive because of the descended tonsils, because of the myelomeningocele, because of the issue with the spinal cord down low. T2 lies to you. White is gray, gray is white. Yeah, that's another good way of saying it. There you go. What else you guys got? Oh, did I have something? Oh, that's a good question, Miriam. I asked because, so Miriam asked, I asked because from what I remember, you only see MS lesions, MS meaning multiple sclerosis lesions, on T2 flare and not on T1. Perfect. So T2, here we go, radiology 301. T2 or flare, let's talk about flare. Flare lesions for multiple sclerosis. Yes, they are flare hyperintense lesions. Specifically, and now we're going down to USMLE step 1, Dawson's fingers. Remember Dawson's fingers, you'll get a sagittal view of the brain. The patient will be sagittal cut like this. And around the corpus callosum, you'll see these fingers kind of radiating up. Those are Dawson's fingers. Those are flare hyperintense. But guess what happens to these lesions after a little while, Miriam? You get burnt out lesions, so they will end up being T1 dark. So you have flare hyperintense lesions, but then they will be burnt out and they will cause little defects in the actual brain parenchyma and they will be T1 dark. Radiology 401 is about to happen right now. How can you tell if it is an active plaque versus a plaque that was active a while ago, a remote plaque, therefore not active now? I'm gonna give somebody 3 seconds to answer that. 3, 2, whose fingers are typing as fast as they can? 1, okay. So you can tell if it is an active MS lesion, if it is post-contrast enhancement. So here we go, let's break it all down. If it's flare hyperintense, it's a lesion. And it's a Dawson's finger, it's a lesion. If it's T1 hypointense, dark on T1, then it's probably been around for a while. It burnt out that little area because it's just simmering in that little area. Then if I gave the patient contrast and it's actually lighting up on the post-contrast sequence, then it is an active inflammation right now. The patient's having symptoms from their MS flare. The other board's question for the neurology residents and the radiology residents, board questions. What do you do if you diagnose an MS plaque up top? What is the next thing to do? Get imaging of the spine. You get full imaging of the spine because there will be MS plaques in the spine as well. I was about to say 100%, but most of the time there are as well. That's MS in a nutshell. For anybody who wants radiology 501, you can have tumefactive MS plaques, which are just these huge plaques. They're not even plaques, they're huge. I'm just gonna go ahead and call it a mass. It's not really a mass, but there's mass-like lesions in the brain that look absolutely nasty. It looks like a GBM, it just looks gross, but it's actually a tumefactive MS plaque. Who wants to go down the route? Any maybe neurology, radiology residents, even med students interested in this? It's a very short differential, but you should know this because you will be questioned on this one day, I promise you. If you have a lesion in the brain that's crossing the corpus callosum, anybody know what the differential for that is? There's about 4 things that are coming to my mind right now. Somebody just start typing one out right now. This is literally, I'm just rambling off the top of my head. If anybody wants to talk about anything particular, let me know. GBM, boom. That's the first one. Glioblastoma multiforme. A GBM, yep, GBM is the main one that a lot of people think about. It can cross the corpus callosum. Somebody may be asking right now who's tuning in, what is a corpus callosum? That's the area that's connecting this side to that side. It's a little area going like this, and it's connecting the 2 sides. Not many things will go through there to go to the other side. One being a GBM. Number 2, what is the main thing that another main thing that I'm thinking about? Lymphoma. Lymphoma. Think about that. GBM, lymphoma. Number 3, MS plaque. Boom, Miriam coming in again. She is a neurology resident. So GBM, glioblastoma multiforme, lymphoma, MS plaque, those are going across like this. Those are the main ones I'm thinking about. I feel like there's one more too. I don't know why it's not coming to my mind, but those are the big ones. What else? Anything else in the brain? Want to go back to, let's go back real quick to Radiology 101. You tell me, is this actual obstruction or not? Hydrocephalus or not? This is the second to last image I posted, or the first one today. Is this actual hydrocephalus or not? And tell me why. I'll give you a couple of seconds to think about it. Go through the algorithm. Go through what I was saying earlier today, or earlier, I don't know what it was, 10 minutes ago. Do you see prominent sulci? Do you see the Sylvian fissures here? No, you don't. Do you see prominent sulci, these deep little caves going in like that? No, you don't. Do you see gyri atrophy? No, I don't. Then why are these so big? Why are they so big? Because it's actual hydrocephalus. So this is actual hydrocephalus. This was the patient with the Chiari II malformation. Got hydrocephalus, looks like this. So the other thing, do you see, somebody mentioned transepidermal flow. I don't know, I don't really see transepidermal flow. You may see it, maybe it's a big screen, I can't really see it from here. Transepidermal flow will be this hypoattenuated area, decreased attenuation, whatever words you want to use, but now you know how to use them correctly. You'll see these hypoattenuated areas like this, and it'll leak into the white matter around here. I don't really see that here. So then that kind of brings me to the point, well, he does have, in this case specifically, it is obstructive hydrocephalus. The brain parenchyma is pretty good. It's not because it's ex-vacuo dilatation in the CSF spaces. It is hydrocephalus. There's no transepidermal flow. Oh, maybe this is more of a chronic issue. So maybe this patient's kind of compensated maybe a little bit on his own, but maybe it's not like the most severe acute process that's happening right now. That's my process when I'm thinking and I'm looking at these cases. Those are the kinds of things that I'm thinking about. What else you got? Let's go. Join today, huh? Nice, man. You got the time right. What else you got? The lead gen. What's going on, man? Anything else? We covered a good amount today, huh? Remind me at the end of this, I can't broadcast this for the next 24 hours. If I hit that button, then it doesn't allow me to save. So I'm going to save this. I'm going to try to upload it to YouTube. I have no idea what I'm doing. I'm going to do it because I'm going to do it for you guys. I want to keep these just kind of archived for everybody to look whenever they need be. We good? What else? Let me know. Anything you guys want to see tomorrow? What's the case for tomorrow? You tell me. abdomen, chest, MSK, head again, heart. What do you guys want to see? Who's dying to see what? You guys type slow. Come on. All right. I think we're good for today. For anybody who joined a little late, I'm going to reiterate everything. This is going to be my 60-second spiel. We're going to go from the beginning. I'm going to put these images back up. This is what I did before. This was the first image. This is ex-vacuo dilatation of the CSF spaces. This is not actually obstruct or any hydrocephalus. This is just because the rest of the brain is completely atrophied. This is a normal brain. These are normal calcifications, choroid plexus, pineal gland right in the middle. Asymmetric ventricles like this, who cares? Don't worry about it. Move on. It's nothing. This is actual hydrocephalus. These guys are big. I don't see any gyri or atrophy gyri or prominent sulci. That's not good. This, going off of those descriptions that we just talked about, is bad. Again, I don't see any atrophy. These are way too big. I don't like that. That's no good. This guy right here, these are cerebellar tonsils. These have herniated down into the CSF spaces down in here, into the cord area and the canal. That's not good. It's going to cause obstructive hydrocephalus. Remember, obstructive is different than, I'm going to confuse myself again. Obstructive and non-communicating go together, and non-obstructive and communicating go together. And remember, this right here is a myelomeningocele. This was, I don't know how old he was when he got diagnosed. That caused everything to descend from up top. That caused Chiari II malformation. Chiari II associated with myelomeningocele. Chiari I associated with the syrinx. That's what you need to know. I'm gonna drink some more water because I'm dehydrated. All right, I appreciate you guys. This was an awesome session today. I'm gonna upload this right now. I'm gonna try. I really hope it works. I'm gonna try to upload this to YouTube right now. I'll put the link up. Dude, you guys are awesome. Great questions today. I really appreciate you. We're gonna keep this up. Until next time. Later, guys.